Good afternoon, and welcome to Research in Action, brought to you by the Division of Research at Florida Atlantic University. If you tuned in on Tuesday, you will know that this is our second Research in Action of this week. We had an extraordinary event on Tuesday, which was in hybrid mode, so also a live session. If you missed it, you will shortly find a recording of the presentation on our website to be found at Florida Atlantic University if you look for Research in Action. Before we get started with today's session, just a few reminders. If you would like to ask questions of today's presenter, please type those under the Q&A button. You find the Q&A button in the bottom of your screen. If you click on that little icon that says Q&A, a little pop-up comes up and you can type your questions there. You can ask questions anytime during the presentation today. We will get to the questions at the end of today's presentation. With that, it is my great pleasure to introduce Dr. Candy Wilson, who is a retired U.S. Air Force colonel and also an associate professor at the Christine E. Lynn College of Nursing here at Florida Atlantic University. She is a women's health nurse practitioner and did receive her Ph.D. in nursing from the University of Colorado at Denver Health Sciences Center. And her military responsive research agenda focuses on clinical care needs for military members on a variety of topics. And with that, I'm just going to turn it over to Dr. Wilson. Welcome. You're muted.
I got to unmute. Thank you, Dr. Scarpinato. I appreciate that kind introduction. And I'm going to say thank you, Dr. Wild Goose Carroll, for inviting me to be present today. And I appreciate everybody coming to hear me give this presentation. So I'm going to go ahead and share my screen here. Okay, so the agenda, I'm going to talk to you today about low back pain, not only as a problem within the US population, but how that affects the young military population. And then describe chronic back pain and how it affects military readiness, particularly from an individual standpoint, and introduce an ear acupuncture technique known as battlefield acupuncture for the treatment of pain, and then share a recent study that we completed on the military population. So why is this topic important to me? As you heard, I'm a retired military officer, and following deployments and so forth in training and rigorous settings, kind of got that firsthand experience of that limited resource setting and having to wear gear, sometimes weighing up to 30 pounds, and having to carry supplies with me on my back or on, in my hands. So a lot of weight, uncomfortable surroundings. I shared this picture of when I was in Afghanistan, where I'm sitting in a Humvee, hard plastic. It was hard to get into and out of. So more chances of not only the additional weight causing problems on the back, but also the weird, I'll say, contorted position sometimes you can get in because of the job needs and so forth. As a nurse, my concern with low back pain was for my patients that I was taking care of, and also as a leader of providing care and access to care. Healthcare professionals also have issues with low back pain. Low back pain, the definition of low back pain is pain and stiffness or muscle tension located typically between the margin of the lower rib and the buttock creases, with or without sciatica. And sciatica is where that pain radiates down into the buttocks or the back of the leg. The pain that I'm talking about today is that symptom, not necessarily the cause or treating the cause, but treating the symptom. And the causes of the symptom and the chronic pain issues are threefold. One being biophysical, that there's an actual structure problem, such as degenerative discs or other issues that can cause pain. Social, such as the job requirements, like I was telling you, getting in and out of that Humvee, carrying gear. But social, like your job, your fun activities, what you like to do, bungee jumping or something like that, putting you more at risk for pain. And then also including if you choose to smoke. Smoking has been tied to chronic low back pain. And finally, the psychological aspects of chronic pain or chronic low back pain, where depression and chronic pain can go hand in hand. What causes the other? Sometimes does chronic pain cause depression, or depression cause chronic pain? It can go back and forth. So with that too, thinking about what is chronic pain, and when you're talking particularly about low back pain, acute pain is typically pain that lasts less than 4 weeks, and it's usually specific toward an injury or what have you, something that you could probably attribute to the cause of the pain. Then you start getting into that gray zone of subacute, which is your 4 weeks to 12 weeks of pain, and then it would resolve. And then finally, the chronic pain is the pain that lasts more than 12 weeks. So pain is not to necessarily be ignored. I know when you get into that chronic pain, tends to be that low level noise or high level noise, depending on the level of that chronic pain. But pain should be evaluated, of course. So concerning factors with low back pain is if there's changes in the presentation of pain. It didn't ever go down the back of the leg, and now it's starting to go back down. You're starting to feel the pain down the back of the leg. Losing bowel or bladder function, signs of infection, a recent trauma, weight loss, or being over the age of 70 are serious concerns if it's accompanied with new onset low back pain or changes in that low back pain. So I just want to put that out there that not all pain should be ignored. But chronic pain is a problem concern globally, with, of course, low back pain being the #1 source of chronic pain. So thinking about it from a chronic a global perspective, we have 577 million people worldwide deal with low back pain. The #1 reason for disability is low back pain, and females tend to carry the biggest burden for that low back pain, with a higher prevalence of years of disability. There was one study I found that there was disagreement in the sexes, that they didn't find a difference in men and women in that pain. But that's not the norm, though. Most studies do say that women tend to carry more burden with that chronic pain issue. Worldwide, the pain peak is normally 45 to 49 years old, and low back pain is more common than diabetes, chronic obstructive pulmonary disease, and other chronic diseases or disorders. And of course, it can worsen with age, because something like degenerative disc is something that generally does happen over time, that the disc spaces within the vertebrae do shorten, and that's been documented on MRI. But the amount of shortening of that disc space doesn't always correlate to the level of pain, the intensity of pain. So it is very much a personal experience in how the body responds to that, those aging changes that can contribute to chronic pain. Oh, I think I'm going the wrong way here. Here we go. So this chart by Chen in 2022 compares the sociodemographic index and age standardized years lived with disability per 100,000 individuals. So along the horizontal line, or the x-axis, is a sociodemographic index, which is expressed from a 0 to 1, and it's calculated based on the country's economy, education, fertility rate. And so the higher towards 1, more developed the nation is. And then along the vertical axis is the age standardized years lived with the disability. So going up per 100,000 people, going up that line is more people living with disability over the time. So where is the United States in this chart? I'm sure we're all kind of probably squinting our eyes like, where are we at? Well, we're way up here. So we, of course, very advanced, our economy and so forth, but we live a long time with chronic pain or with the disability of chronic pain. Because the black line, if you see that black line, kind of looks like almost a sideways S, is where you want to be kind of aligned with that line there. But we are in the US way off the charts. Approximately in the US, approximately 20% of Americans have pain most days. And this was reported from a National Health Interview Survey in 2019. So those of us on this call, 1 in 5 of us have pain most days. And those of us that have pain, 40% of us, it would be because of chronic low back pain, being the #1 contributor to chronic pain. And if we have low back pain, we're more likely to miss work. And quite often the #1 treatments from that National Health Survey that they reported was they use physical therapy and massage as their top treatments. Back and neck pain topped other health conditions in direct care costs. That's $134 billion. And it's higher than diabetes. I mean, I was just astounded by that number, and I'm sure you all are as well. The majority of the direct care costs are paid by insurance for low back pain, but there's still a lot of out-of-pocket that occurs when trying to manage that chronic treatments that maybe massage or say chiropractic, something like that, that insurance may or may not necessarily cover. So moving now to the military, because the military, US military, of course, is made up of the US population. So we've already talked about this alarming level of risk and numbers of people who have low back pain. But spoiler alert, I advanced my slide too early, but 77% of Americans today, age 17 to 24, are not qualified for military service. Of course, that's got our generals and admirals up in arms. You know, they're very concerned about, preparation, the ability to have, a fit force. The 3 top reasons right here are listed. And of course, the first 2 highly correlated, connected to the risk for low back pain. And so, quite often we've heard those stories, like someone wants to get into the Marines, so they lose 20 pounds, get into the Marines, and then old habits come back and gain weight, what have you. So there's things that can still put people at risk, even if they still meet the mark. So joining in the military service, they can join with a waiver. So let's say they don't quite run well to get in, their time isn't good. And then they improve it, they pass the test, they get in, and then again, back to old habits. So making sure that people continue to keep those good habits if they do qualify and make it into the service, which is a good thing that the military is starting to recognize in our basic training platforms. We're starting to integrate a lot more athletic trainers in those settings to help prevent injury very early in our military careers. So the number of people in the military, it's about 2 million service members, where 1.3 of those 2 million are active duty. And that's only 1% of the population, as we're on this call today, only 1% of the population is in the military. So very, very small numbers that will respond to national defense needs. And last year, we had 20,000 additional troops sent to Europe in response to the Ukraine crisis. So again, that minute's notice and to be ready. And to get ready, of course, takes a lot of training too. So I've included some slides that I was able to find on some opportunities that military members get to take advantage of to train. I don't know about that, that line thing coming down on the boat there, but that's why I wasn't in the Navy. But anyway, but readiness, low back pain is a real issue, of course, thinking about the military. And the specific study that just came out last year was from the Army sample, where they had the odds of experiencing back pain were, of course, older age, obesity, enlisted rank, and female sex. Okay, we're going to start seeing a theme here as we go along too, because then following that highlight was a systematic review I found where they looked at 8 studies in military research and found that the factors listed were previous history of low back pain, less physically fit, female sex, and lower rank. So we're starting again to continue to see that theme. And then one thing that was, I think, important to point out too, that low back pain was a prevalent issue following deployment-related injury, and that contributed to worse mental health outcomes and quality of life issues. And of course, that's a concern from the mental health and the preparedness of individuals. So considering then additional statistics, again, just to drive home who's the most at risk, you can see right here from the Department of Defense, or DOD, and Veteran Affairs, or VA, low back pain guidelines were just put out last year, and great resource for us that provide healthcare to this population. And they shared what they found in their prevalence rate, and found that, again, women, females most at risk, members in the Army and Air Force, Black non-Hispanic members, and then finally moving down to military occupation, the top 2 were healthcare and admin and supply. And that goes along, this is just Candy Wilson's view, but being on the inside with this, it's those are the occupations that are less likely to be physically active, and versus the other occupations get those opportunities to take time to do their physical activity on a regular basis. So using those DOD VA guidelines I referred to earlier for the prevalence rate, these are the usual treatments that they outlined in that guideline. The top one being non-steroidal anti-inflammatories, or NSAIDs, which is ibuprofen, Aleve, those type of medications. They actually recommend not using Tylenol because you're not getting that anti-inflammatory support. They recommended duloxetine, which is an antidepressant drug for chronic pain, for chronic low back pain, but that doesn't necessarily mean the person's depressed. Now, they do go hand in hand, but it doesn't necessarily mean that they are depressed, but there is a good response regardless of depression or not. Non-surgical treatments can also include radio frequency ablation, which I have a small picture of that right there, where the surgeon goes in and separates the nerves to appraise the pain or experience the pain. And then they also recommend acupuncture, particularly for that chronic low back pain. So I'm going to tell you a little bit about the novel low back pain treatment that is known as battlefield acupuncture. So what is battlefield acupuncture? And just wondering, I wish we could go see face to face, because I'd love to know how many of you have heard of it. Because it's a great technique, and I'm sold. It changed my practice as a women's health nurse practitioner. But what it is, it's an ear acupuncture technique, and it uses semi-permanent needles. It was developed by Dr. Richard Niemsau in 2001, he is a radiation oncologist and a medical acupuncturist. And it took him a couple of years to refine this technique. And he's got it down to a science now, and now that led to a lot of the training that I'll talk about later. He's a retired Air Force colonel, and now an Air Force civilian at the Joint Base Andrews there in Maryland. He was, as a radiation oncologist, he was really struck by the amount of pain cancer patients had, and what he could do in addition to support their needs as a physician. So, he developed this technique, and again, it is indicated for acute and chronic pain. This treatment, it's a protocol, as I'll continue to say over and over, because I want to emphasize that it's not truly acupuncture in a traditional sense. And I'll make that distinction a little bit later. But the nice thing with him refining this treatment and seeing clinically and collecting his own data, he showed the effectiveness of it and was able to secure a $5.4 million Health Executive Committee training grant. And that's now completed, where he trained thousands of physicians, nurses, and medics across the VA and DoD. But you pretty much can't walk into a DoD or VA healthcare facility without, you know, 1 or 2 or 20 people knowing BFA, because it really has permeated throughout these systems. But one thing I want to point out in this picture too is that Dr. Niemsau is holding a white and tan card, it looks like. But why I want to point that out is because that flat item on the other side, you can't see the other side of it, but it's like bubble card there, and you can punch the needles out into a little, it has a little introducer. And the reason why that's so important is because that right there contains 8 needles, as I said, but you can see how compact and portable that is. So, because the maximum treatment is 10 needles per person. So already just like little over 1 card there would treat a patient. So if you had like 20 of those or whatever, you got almost 20 patients you could take care of. So very portable, easy to take with you. And let's say, you know, you're going on a humanitarian out of the country or something like that, and your healthcare provider, you could easily take this with you. It's good for treating acute and chronic pain. And I'm going to move on for the interest of time here. This right here is the placement of the needles on the ear. It looks like little, I call it little eyeballs there, but anyway, what it is the black center is where you're aiming to put the needle, but that pink area that's around there is the zone. You're still okay to put the needle there. Again, that's the protocol aspect of it versus you know, assessing for acupuncture points. It takes the 5 needles per ear, and the predetermined order, because all these needles go into a certain order, not only just the point, but the way you put it in. And the patient walks in between each needle as it's placed. So put a needle in, they walk, come back, put a needle in, and then you continue to assess pain levels with each needle. And you typically want the pain to get down to like a 1 or a 2 versus some people, the pain goes away, but, you know, and that's awesome and that's great, but, you know, it shouldn't normally get to that level. And then you can put the needles in every week or every other week, as much as, you know, as often as needed to help manage the pain. And then needles will stay in like 3 to 5 days, and they usually fall out on their own. If you see the penny right there, that is right next to it is the needle. So very, very small. And in the ear, it looks like a little gold stud. There's 3 theories why battlefield acupuncture works. One is from the embryologic levels and how it affects different areas, somatic functions in the body. Next is energy, balancing energy, the yin and yang theory. And then finally, the last theory why they think battlefield acupuncture works is because of the endorphin theory, which is the feel-good hormones being released into the bloodstream and the cerebral spinal fluid. The advantages of battlefield acupuncture is it's easy to learn. We can train healthcare providers in 4 hours, and that's from physicians to our enlisted medics. It truly is something that you can knock out very quickly and become fairly proficient at providing this intervention. 80% of patients consistently over studies, over clinic data collected and so forth, usually right around 80% of patients respond. Again, not pain down to 0, but, you know, a pain reduction. The needles come in the sterilized card that I was telling you about, that small card that fits in your pocket. And it takes less than 15 minutes to put those 10 needles in, because remember, you put needle in, they walk, needle in, walk. No need to disrobe the patient. You can do, individual setting, group setting, what have you. You could do it, in the middle of a field. Needle disposal is not an issue because they're very small, less likely to cause any, secondary injury if someone were to get a hold of it. Rapid pain relief usually lasts 1 to 3 days. And there's little to no risk of infection. Anytime you're breaking the skin, though, of course, there's some risk. So you got to give good instructions and so forth. But there have not been any serious infections from this technique, and probably count on one hand how many infections there truly has been. There's different types of metals that you can use that have a different kind of not a different response. It's for different needs. I'll just leave that. But most of the time we use the gold, and those gold needles, being the cheapest, are under $1 a piece. So now I want to move into the research study findings that I'm so excited to tell you about. This was funded by the Tri-Service Nursing Research Program, and I definitely want to give a shout out to them. They support military research topics, particularly for nurses to study. And they have a line item from Congress. They get $6 million per year to fund research, and they've been recently plussed up to $13 million this past year. And so really excited that Tri-Service Nursing is available for us to look at military specific issues. And now think about this study. The goal of this 8-week study was to determine the outcomes of battlefield acupuncture on pain, sleep, and physical activity in the military population with low back pain. And this study, let me tell you, takes a team. I have physicians, I have physical therapists, I have other nurses, of course, the statisticians, wow, you need them. And then finally, this very special thanks to Dr. Richard Niemsau, who was involved in the study and provided expert consultation. This study was completed at Joint Base Andrews, Maryland, Air Force One, and flying a lot of the VIPs around from our federal system. And we recruited military members using flyers, and we put flyers everywhere. I mean, you name it, we had flyers to tell people about the study. Snowball sampling, which is word of mouth. So if we treated someone, hey, do you know anybody who has low back pain? And everybody knows, everybody. So, a lot of good word of mouth went out. And then finally the commander's briefings. So anytime we had a group of military members together, we would come in and tell them about our study. Now we collected 2 types of data. We collected data that was self-report, which is your instruments that I have listed there on pain, disability, sleep, and quality of life. But then we also collected objective data, which is data that's collected either passively by a device, such as the ActiWatch that you see here, that picture, or data that were collected by another individual without the person saying what that number is or that value. So these are the inclusion and exclusion criteria. So anybody with a military member with pain greater than 3 out of 10, they had to have a disability index of greater than 20% and no anticipated long time away while they're in the study. The exclusion criteria were pretty much the very severe concerning issues that we couldn't include in the study, because honestly probably needed to be evaluated further if they had any of these criteria from the exclusion list. Our final sample, we had 48 participants who met criteria and were randomized. 35 participants completed all 8 weeks, which is usual, because they came in every single week for 6 weeks, and then they had a 2-week washout. So that's kind of normal to lose people over time. And if you can read this eye chart, maybe it looks better. Yeah, maybe you can see it on your screen better. But we lost, I think it was 6 people due to COVID shutdown. And that's pretty much when we shut down the study because, you know, it just not knowing what was going to happen next at that time. One thing I want to point out too, is you can see the average age for our study was 34.7. And if you recall back, worldwide, the average age for low back pain peak was in the mid 40s. So we're already 10 years younger of a sample that met criteria for chronic low back pain. And then there's also more women in the control group than the treatment group, which was a problem in our analysis, and I'll probably get to a little later. But looking at this slide right here, you can see that, and I don't know if you can't see maybe you can see my cursor, but if you can't, in the overall column, you see male and female, and you can see females 40%, about 40% in the overall, the whole study, which in the military right now today, it's about 18% of the population is women, but we had double that qualified in that for this low back pain study. So we had over, not sampling, but recruitment of women who were willing to take part in this study. So is there more disease? You know, but I think it's going in line with what the literature was saying about more women. So me talking about the problem between having more women in the control group, I just want to tell you about our usual patient in the 2 groups. So our usual person in the intervention group, which when I say intervention, I mean people who got battlefield acupuncture, was an Air Force senior enlisted male that was white, non-Hispanic. And then compared to our control group, which was, we pointed a pen light to their ear, but did not turn the pen light on. So of course they didn't know that they weren't getting treatment. So that was our control group. So that the usual person in the control group, though, was an Air Force senior enlisted female that was white, non-Hispanic. And again, I'll get to why that's important here, hopefully, in our analysis. So pain was immediately reduced in the battlefield acupuncture group, but this effect only lasted a few days. Again, in line with everything we know clinically in the literature. And interestingly, over time, both groups did get better with pain. They trended downward. Again, as chronic pain, it comes in, it'll go in waves. So you all lining up with the literature. And with the pain scale, I wanted to tell you a little bit about this too, that because it's important when I show you this slide here, the average pain score, so they came in every week. So before we did anything, when that's before the battlefield acupuncture or the control, we assessed their pain before we did anything. And the average for the battlefield acupuncture was 4.2. And the pain level right after was 2.7. So we're already sitting at 1.5 difference. That's not really exciting. But if you let me have just a second here to explain why I get a little excited about that. So 4.2, when we first treat them, if you look at the qualitative information below a 4 here, a 4, if you can read that tiny print, if I could read it for you, distracts me, can do usual activities. So when you're thinking about somebody who's working on Air Force One or something like that, because we're going around Joint Base Andrews, so the pain is distracting, but still can do usual activities. You don't want a distracted person. You want them focused on what they need to do. And remember, immediately after treatment went to 2.7. So if you look at the qualifiers of that, 2 is a notice pain does not interfere with activities, and 3 is sometimes distracts me. So a better indicator of what the pain is doing to them, how it's affecting them. So I don't know. I get excited about that. So hopefully you'll appreciate that as well as I did. Next, moving on to disability, there was a mismatch concerning given that the reduction in disability is the byproduct of reduced activity. So one thing that was that individuals said was that the battlefield acupuncture group reported less disability related to pain. Yay, exciting, right? Well, the balance tests were no different between the groups. Okay, now this is why it's important between the men and the women. I pointed out what's the usual person in the control group and the usual person in the intervention or BFA group that I highlighted, I think 5 slides ago. So that's because women, when you're doing your flexibility test, the flexion test and so forth, women historically have more flexion. So that can interfere then with the analysis just because of who they are and as far as their sex and how that can influence their ability then to carry out those tests just by virtue of their sex. Because that, we know that there's a lot more flexibility of the joints and what have you. And however, even though I said the first bullet, the BFA reported less disability related to their pain, there was no difference in their ActiWatch data. In fact, the battlefield acupuncture group reported less activity as time went on, which is a military leader. If I'm a commander, that's a concern because you want your troops to be active and physically engaging, not reducing activity as a way of treating their pain. Insomnia improved in the BFA group, though not statistically significant, but definitely an improvement. Sleepiness did improve, again, but it didn't match the ActiWatch data. But in the end, though, it wasn't as exciting as I thought it would be because really the ActiWatch information and how it's calibrated, anything above 75% sleep efficiency is very, very good. So pretty much all of our participants, whether it was BFA group or control group, were above 75%. So if you're already doing great, how can you do greater kind of thing? So therefore the objective information that we received for this part wasn't as contributory anyway. And then as a side note, because opioids are very important to us as society, none of the military members were taking narcotics during the study. There was some reduction in muscle relaxer medication. Otherwise, the medication stayed the same throughout the study for both groups. Pain scores were lowered in the weekly interventions, but didn't sustain. And but this lines up with findings from other studies as well, that it didn't matter if it was low back pain or surgery pain or whatever. These other 2 studies, they initially decreased, and then there's something, then the pain would return unless you did something else, like started the NSAIDs or ibuprofen, what have you. Also, our study, we did one-on-one. So if I went in, gave the battlefield acupuncture or the control, one-on-one interaction, and other studies have the one-on-one, but there's a great study with a group intervention, same results. I mean, if they had a group of like 5 or 10 people sitting around giving the treatment, and they too had the great, initial response enough to get other treatments to start working. Participants in the intervention group did decrease their disability score, but that did not increase their physical activity, which the DODBA guidelines recommend that the clinician directed physical activity improve pain, disability, and physical function. So being engaged with the person with chronic pain as a provider. And exercises, core exercises are very important and recommended. And I also want to give a shout out to my colleagues here at FAU, which is Drs. Park and Kraus-Perillo, that showed that movement-based mind-body interventions are effective for treating low back pain. And so with their review, they found that these activities reduce, like I said, reduce pain, but the psychological distress, such as depression, anxiety, it reduces the pain-related disability and improves functional ability. So getting military members to do yoga, it's becoming more and more integrated in the military, but, there's still some that, yoga, I don't know. A couple of years ago, I had like a 220-pound Marine telling him to do yoga. And yeah, it took him a minute to get on board, but he finally got on board, and it did help. But the main thing, the goal is to get our military members back into the game with a manageable level of pain if they're experiencing that chronic pain. Moving on to insomnia and how that relates to other research. My good friend, Lieutenant Colonel Betty Garner, who you see in this picture here, giving the BFA, in her study, also funded by Tri-Service Nursing, another shout out, that insomnia was improved as well in her chronic pain study. So I know I'm kind of up at time, but if I could just have 2 more minutes just to kind of go through just a couple items here. There's an array of options that limit dependency on harmful drugs, and such as physical options, ice, heat, massage, physical therapy, chiropractic, and spinal manipulation, in addition to the acupuncture. We already talked about movement, mind-body, relaxation techniques, and mind-based, such as cognitive behavioral therapy. The main thing as well is to set realistic pain management goals. So from provider to patient, what does the patient want to do? What would they like to achieve? And what is that acceptable level of pain? Because a lot of times with chronic pain, you may never get it to zero, without extreme measures, but I'm talking about clinical management. And then finally, the patient management goals, and voicing them from the patient to friends and family members when it comes to being part of social activities. And then you can see my list here of incorporating other treatments that I somewhat highlighted there just a second ago. And then also, if they smoke, get people to stop smoking, because that there is a correlation between smoking and chronic pain. And the study confirmed other studies, as I highlighted, and it's another option for providers. But I think the takeaway is to expand state practice acts to get this outside of the DoD VA, to offer it to the general public. It's cheap, and it can be portable, great for rural settings or areas of limited resources. So kind of ran through the last couple slides pretty quick, but I would definitely welcome your questions and appreciate your time today.
Thank you, Candy. As a reminder, if you have any questions for Dr. Wilson, please post those under the Q&A button in the bottom of your screen. We'll go through them as they come in. Candy, it sounds like in comparison to some of these other measures that you mentioned, like yoga and chiropractor, those are difficult if you're deported, I would think. Limited space and, maybe not the time even. Do you view that the battlefield acupuncture is a good alternative in the battlefield?
I would say adjunct to it, because it's funny. A lot of people do yoga in the battlefield. Actually. Not of course, this is, I'm talking about in the base, the home base and so forth. So I think in all those things kind of together is very important to incorporate and to include for a military population.
Healthy lifestyle, and then maybe battlefield acupuncture. Okay, we have a couple of questions from the audience here. How do you do placebo? You showed those data that you had on your study. How do you do placebo for battlefield acupuncture?
Oh my gosh, I bet I know who asked that question. That is a science all by itself. What is placebo to acupuncture, right? So I don't have the book here, but there's a whole book on it. What I did for this study, I consulted Kapchnik, I'm trying to think of his first name. He's up in Boston, leader in acupuncture research. And so the placebo for this group, for this study, was we put a laser light pointed at each of the BFA points, but didn't turn it on. We kept the protocol the same, other than we did not put any needles in. So like we would put the light on for like 10 seconds. Well, it was 10 seconds exactly, 10 seconds exactly. And then have them walk, come back and assess their pain, same thing. So everything was carried out the same.
Interesting. In order to participate in the study, did the participants had to have a certain level of lower back pain? I mean, it's somewhat subjective, right? If somebody asks you from like a scale from 1 to 10, what's your pain level? Everybody will say something different, even if the pain is the same. But did they have to be within a certain range of pain to make it into the study?
Yeah. So to make sure we didn't have that bottoming out effect or floor effect of the number, they had to have at least a pain of 3 or above, and they had to have at least 20% disability on the index, that self-report survey.
Yeah.
And we used the Defense and Veterans Pain Rating Scale that I showed that had the qualifying information. So that way, even in the clinic, I used that because when someone said their pain was a 4, I would actually read what is a 4, and then they would confirm, yep, it distracts me.
Okay, very interesting. We have a very specific question here. Is battlefield acupuncture blocked by naloxone?
I don't know. I'm thinking about the pathways and the theories and why we think battlefield acupuncture works. But I can't think of a reason that naloxone, I can't think of a reason that would be blocked. Not from what we know how battlefield acupuncture works as of today.
One of our attendees mentioned that she missed the QR code. Can you share your screen one more time with the last slide that you had on there? So our attendees can get the QR code on it.
Yes. Let's see if this one's it. I hope I do it right this time.
Yep, it's up. It's great. So you mentioned a few times that depression and lower back pain are correlated, and have there been any studies and also comparisons between civilians and military personnel? How the correlations between, or the combination between depression and lower back pain, what the correlations are? Are there any differences?
Oh yeah. So the chronic pain triad is the depression, pain, and insomnia, the sleep disturbances. So it's kind of they all kind of go together. So a lot of times, what I'm seeing in the literature is what comes first. What causes what's the correlation with that? So is one causing the other, or do they just correlate together? I think that's research that definitely needs to be addressed to break that cycle of that triad, and to, if nothing else, just improve quality of life for people with chronic pain.
Yeah. Okay. One other question here. I'm just going to read it because it's a longer statement. I was just wondering whether you also evaluated the agreement between the self-reported sleep questionnaires and the actigraphy in this specific population. In chronic pain patients seem to exaggerate the self-reporting compared to the objective measurements. Do you expect a similar result here?
Oh, yeah, and that's exactly why we did the objective part. So I really appreciate this question. So the to say like the disability got better, but the activity for our battlefield acupuncture group, I'm speaking specifically about the activity, not just the sleep, but they actually showed less activity. So my concern is, I think, a little bit different than probably the person asking the question. So hopefully I can, I can be more, give a little more insight into our findings, is that, that we think what they did was they got better in their disability because they were less active. So that's kind of like their way of managing the pain, which actually, because otherwise you would think, oh, their disability improved, so battlefield acupuncture improved their disability. Well, is it that, or was it the fact that they're not moving as much?
Yeah.
So I think I kind of took a little different approach than the question originally sparked, but happy to continue to dialogue, and would love to, get an email from that person too. Because I think it's fascinating question. And we pondered with that too, as we were designing the study.
It's almost the chicken and egg thing, right?
Right.
What causes what here? So yes, so to any of our attendees, feel free to contact Dr. Wilson. You see her email address on the screen here. So, okay, with that, we are at the end of our questions, and also pretty much at the end of our time. Thank you very much for presenting. Very, very interesting topic, very important topic, I believe. So thanks again. Thank you everybody who called in, and we hope to see you at our next Research in Action. And have a good rest of your day.
Thank you. Appreciate the opportunity.